Right. Hello, everybody, and welcome to 340B Ladies Who Lunch and Learn. We are so excited to have you here. I don't know about you, but it feels like we were just here last week. This month has blown by. So we will jump right in because we have a ton of content to cover, and there has been a ton that has happened since we saw you last. So we are going to be talking physician and clinic administered drugs and best practices. We're going to start though, poll question, who's in the room? Don't forget to introduce yourself in the chat. So are you an FQHC, lookalike, other type of grantee, hospital, or 340B friends and family? And you know we love you all. So it's really happy to have everybody here. And as far as the polls going, FQHCs are still in the lead as usual, but lots of hospitals, lots of 340B friends and family. And so welcome everybody. And
we've got one other grantee. Look at that.
It's true. And if you are the other grantee in the room, shout out what type of grantee you are in the chat because we would love to know. And so looking forward to hearing from you. Seeing like, STD clinic. Welcome, Carrie. And so as far as our fun poll question for the day, what type of late summer activity would you like to sneak in before fall? And so some time by the river, state fairs, baseball games, beach. I will say Maine is starting to get a little bit cold for beach. And the other would be attend an outdoor concert. And so that is what I have done most recently. I just saw Kenny Chesney last week and it was fantastic. So ladies, what about you?
I would choose the beach with a book at the water just to relax by the beach and read. What about you?
Yeah, I think maybe these pictures are my pictures. The hang by the river, we just went on a long bike trip, a week-long bike trip, and it was really hot. And every opportunity that we rode our bikes past a river, we went and jumped in the river, and that was really fun. So if I had a chance to do that again before summer wrapped, I would probably do that.
Nice.
Yeah. I would also be by a river. I'd probably go camping by a river.
Mm-hmm. I love it. Awesome. And as far as the poll goes, we are seeing that relax at the beach is definitely winning, and then followed by hang by the river, and then lots of responses too for state fair and the outdoor concerts. So awesome. And at this point, you have already met me. I'm Felicity Homestead. I'm the CEO at FQHC 340B Compliance and one of your many hosts today.
And I'm Lanika Ellis, the Director of External Audits here at FQHC 340B Compliance. And we are happy to have our guest host, Hannah.
Hi, I'm Hannah Rowell. I'm a senior 340B consultant at Draft & Tucker, so a full-service CPA and advisory firm. We serve healthcare clients and have a specific 340B team within the larger firm. So happy to be included.
And I'm Chelsea Violet. I'm the COO at FQHC 340B Compliance.
Right, and at this point, I'm passing it over to our two experts in the room.
So today, talking about physician and clinic administered medication, one place that we want to start is looking at what HRSA expects around when you make the decision to administer 340B drugs. In the data request, they will request that you provide a list of all drugs that were administered. This is across all your sites as well as your pharmacies, all accounts for all of your sites, and they will ask for an invoice for each site, for each account. They'll ask for you to list all of your parent grant associated sites as well as the pharmacy sites and the 340B purchases during the audit period. As well as providing a Medicaid billing form for each site that administers or dispense 340B drugs. And this is for each state that you bill Medicaid fee-for-service for. And then one thing that's not in the data request list, but is often requested during a HRSA audit is the template or the confirmation that you are doing some kind of inventory reconciliation to show oversight of your 340B drugs.
Yeah. So when I feel like in the 340B space, we talk a lot about kind of challenging items. I think clinic administered drugs are really a challenging piece, particularly for clinics. So community health center clinics, maybe even rural health center clinics. I think it can be hard. It can be challenging. So I'm glad we're spending some time today to talk through kind of how to approach that. When I think about, if I'm at a covered entity and trying to just get a grasp on their current state related to clinic administered drugs, which full disclosure, I'll probably interchangeably call CADs throughout this presentation, but
Yes.
meaning the same thing, CADs, physician administered drugs, basically a 340B purchase product that you have on the shelf at your clinic. So some of the first things that I would do before you even like get too far down the path of revamping your clinic administered drug process is to really think critically about like what types of medications you're purchasing and using at your health center, and what type of account each medication is being purchased on, and maybe why. Is it just because we've just always bought this on our 340B account and that's just the way it is, or is this an opportunity to evaluate even what medications your organization has decided that you want to stock in clinic, or would it be more equally appropriate for some non-urgent items to send the patient to the pharmacy for that particular medication. And then always when you're thinking about any process, strongly recommend that you go and you speak with the clinic staff, the folks on the ground who are actually doing this work, so you can kind of understand a little bit better about their process and their workflow. And that will help you design a clinic administered drug process that isn't like doomed to fail. Because if you design something that's incredibly complex and doesn't really work with the workflow of your medical assistants, for example, it's going to have a lot harder chance of being successful. So those are some of the things that I would do before even like getting too far down a CAD road. When we think about clinic administered drugs, the kind of those core 340B considerations are the same considerations you hear over and over again in 340B. So it's diversion, patient eligibility, and duplicate discounts. I think kind of the cool thing about CADs is that if you were able to prove that each unit you purchased went to a specific patient, kind of in like one swoop, you could essentially prove that the drug was not diverted because you know which patient received it, and that it went to an eligible patient because you have a record of that patient's care. So you're kind of like, hitting two of those items off the list by just getting from the purchase to the patient, which is not as necessarily as easy as it sounds. But then I don't want us to lose sight of kind of that third prong, which is that we also need to kind of incorporate safeguards for making sure that if we're using 340B purchased clinic administered drugs and those drugs are being utilized for our Medicaid patients, we need to think about the duplicate discount possibility there and put in place safeguards to prevent the duplicate discount. So they're kind of like some of the key considerations in my mind. Yeah. Monica, do you want to talk about diversion?
Yes.
Great.
So when we're thinking about diversion in our clinic administered drugs, we want to, when we're selecting the formulary, thinking about what care is provided at each of those clinics. Different clinics may require different type drugs. You may have an optometrist that needs eye drops, which may be much harder to track than say your women's clinic that needs depot. Also thinking about eliminating redundancies when you're identifying the cost-effective options for each of your drugs. And then depending on your state's Medicaid requirement, is not all or nothing. So you can use 340B and non-340B drugs according to your state. And also when we get into talking about diversion, where will you store your drugs? Who will have access to the drugs? Are the nurses able to go in there and just take some ibuprofen? Are providers going in giving out boxes of albuterol? So just those considerations around diversion And then we kind of get into the drugs that are easy to track, creating a formulary, looking at the drugs that say that are going to go into your emergency kits. Sometimes those are harder to track. Are your multi-dose vials harder to track? But having a sample or limited formulary will help with the decision of which drugs you are going to utilize.
Yeah, and kind of to build off of that point, like once you've created your formulary of like, here are the drugs that we've decided as an organization we're going to purchase on our 340B accounts and we're going to stock, making sure that you're really bringing in your purchasing department stakeholders as like kind of partners in that, because you can make the greatest list of like, here's all we're buying on 340B. But if your purchasing team doesn't really understand why it's so important to stick to that list, then over time, some of that, what you think is your 340B opportunity and risk, there could be other items purchased on those accounts that you just aren't aware of. So that's something that I would keep in mind, is like, it's kind of like a larger team effort with clinic administered drugs. So this is our next poll question, which is asking you all, like, how are you currently tracking your clinic or physician administered drugs? Do you use this tracking software? Do you have an electronic, maybe an Excel spreadsheet, paper logs? Maybe you don't have any 340B purchased clinic administered drugs. That's certainly an option. And then maybe you don't know how that tracking is happening at your organization. So I'd be very curious.
Right now, we have the majority are paper logs.
Okay.
We do have some that do not have a clue, which a lot of us started there. So great place to start. Tracking softwares is coming in second now. And then we have some that are using electronic spreadsheets. And then we have some that do not have clinic administered drugs.
Yeah. That's a more even mix than I think maybe I would have guessed. I mean, again, still paper logs went in and out, I guess. You know, a hard habit to quit on the paper log front. But all right, thanks for sharing, everybody. Okay, so, you know, as far as you think about your options, and Lindy and I talked about this in preparing for the presentation, I think there are some great maybe tools and softwares and vendors that offer products that can track your clinic administered drugs with great detail. But, you know, when we paused and thought, you know, there are a lot of clinics in the 340B program that maybe would have a low volume. Maybe they don't purchase all that many clinic administered drugs. And the effort, and more importantly, the expense of implementing a tracking software might kind of outweigh the benefit of the 340B discount that you're getting on your clinic administered drugs in the first place. So we just wanted to offer to you that there are ways to improve your 340B clinic administered drug compliance that don't necessarily require, like, you must have this top of the line modern digital methodology. There's kind of a spectrum of how you can make sure that you're overseeing your purchases that you're making. So, you know, what is that ideal state? The ideal state would be able to track every single unit that you buy, from the unit all the way through your organization to the exact patient that received that product. But that's really pretty hard to do. It would require either a software solution or a lower tech but really high labor intensive method to do that. But I want to offer that there's a difference between like just not tracking your CADs at all and tracking every single unit perfectly, right, and maybe moving on the spectrum towards a better state is where we can strive for. So, you know, what is better than maybe not tracking at all? I would say focusing on the records that you're getting out of your electronic medical record and trying to improve the consistency of that documentation and the accuracy of the documentation, and really like challenging yourself. Like maybe your IT or business intelligence team is running a report of all the administrations from your EMR, but really taking it a step further and trying to understand, are the units that are being documented, is that really reflecting what was utilized for this patient? And does this drug name really make sense with the actual drug that we're purchasing, because there can be some variation there when it comes to the staff who are actually documented in the medical record. So kind of improving that data that you're getting out of your EMR is an important first step. And then next, I would say, if you have all this dispense data or administration data from your EMR, then comparing that with how much you're purchasing to assess whether it's an appropriate level of documentation to match what you're purchasing. And then you would research any discrepancies. So for example, if, you know, Clinic A purchased 50 doses of Depo a month, then I would expect that I would have maybe 48 to 52 patient records of receiving Depo at that clinic every month. And if there was any big discrepancy, then I would have a question about, like, why are all these units of Depo leaving the shelf but not resulting in EMR documentation that's flowing through to my report? So, you know, it's different than knowing exactly which dose of Depo went to which patient, but if you have 50 doses used and 50 patients, then that's quite a long way towards your compliance goals. So just a thought suggestion.
And before I get into that, to build off of what Hannah was saying about looking to see what your EMR reports, it could be something as simple as, I had an instance where they were ordering the TB skin test in their software. They were able to track everything and they could not find where the TB skin test tracking was. And it was because it was ordered as a lab. So they had to then run a report differently to be able to pull in those, to track where those drugs were used in the lab. So when we get to talking about tracking inventory, and like Hannah talked about, for me, my background is the FQHC. We had about 17 clinics at the time, and we were using paper logs. And we needed a solution that was cost effective. But they were not willing to buy the solution, like a fancy software, because we did not dispense enough drugs to justify the cost. And just putting our heads together, and like Hannah also talked about, looking at what the clinic was already doing. Most of the time they're doing something to track. It may not be hitting every single mark of what you're looking for. So like, say the nurses, most of the time, if they have to do an order, they may have to provide the purchasing specialist with what their balance on hand is currently, to add to whatever they're ordering for their purchases. Or when they're receiving the drugs in, they're logging how many they're receiving. So we have one box checked, then looking to see what is utilized and bringing in, matching out those purchases. So talking about your medical record reports, we kind of already talked about that. Manual logs or paper electronic, making sure that your drug and waste is also tracked by the specific patient if it's not expired. So having a spot in those manual logs, either a separate log for the waste or including it in with that drug's log. And then the fancy barcode scanning systems, we usually see those in hospitals, not at our smaller grantees, but I'm sure that's what we would be the ideal for all of us to have.
Yeah. I think, Lenika, you said something that reminded me. You said something about CADs that were used in the lab setting and how that was hard to pull into your electronic medical record reports. Something else that I think I've encountered is if you're using 340B purchase medications at all in your dental clinics, and then maybe your dental teams document in a completely different EMR, then that's another place where you're like, oh, those are almost certainly not going to be coming through the administration report that would be easiest to create, so kind of thinking about all those little like one-off scenarios, those emergency boxes, the different types of things that might not match with the traditional setting that you're pulling from. But yeah.
I want to add to that, Hannah, before you move on, about the emergency boxes. One thing I've seen with that, a problem, is a lot of that stuff expires before they use it in those emergency kits because they're not consistently using it. So they don't think about a waste log there. They're just replacing the expired medication. So that's one area that if you have emergency kits, go ahead and include a waste log in the kit. So it's already, even if it's just a paper log, it's something that's already there when they're changing out those medications.
Yeah, I think that's a great idea because the emergency box, like, hopefully we'll never use anything in this
Right.
box. We'll probably use a few things, but my best case scenario would be that they would expire before they needed to be used. But yeah, that's good. That's a good
Even
flag.
a documentation of when things are used from the emergency box. If you think about like in hospitals and things, when the code cards get used, a lot of that is done on paper documentation and isn't documented the same way that normal drug administrations would be. So thinking about the process for how the document, or excuse me, the administration in the moment, in addition to any waste or expired drugs or anything, is managed, and how that gets incorporated back into your kind of master log is important.
Yeah, that's a great point.
But I can share something that I've seen someone do around that. During the emergency, they have to fill out the form of everything that happened during that event. And most of the time, whoever, if it's a nurse manager, just documenting what happened during that event, documents if something was administered to that patient that was in the emergency event. So that's another way if you're trying to figure out, hey, this went away, but I don't know where or who it went. And that's a deep dive into, looking for that documentation, but it's a starting point to see where those drugs went.
Yeah, that's a good point. Like you might have an incident report mechanism to look back at. Yeah, that's a good idea. So speaking of the documentation, we talked about some places where maybe you wouldn't have traditional documentation in your medical record. But let's shift gears and talk about that classic electronic medical record documentation. If you're thinking about building that formulary, thinking about deciding like what items can we really purchase on our 340B accounts and track them appropriately, you might think about which drugs get documented in the EMR the most reliably or consistently. And some of the things that I've seen that tend to work well are drugs that are actually administered to the patient. You're probably going to have ample medical record around the administration of a drug. So Depo, Bicillin, for example. A little harder things that get dispensed. So I'm just going to give you this albuterol inhaler to go take home and use. I feel like that's seems to be a little bit less consistent on the documentation in the medical record. Another thing, if you're like looking at the scope of your program and trying to decide what do we want to purchase, certainly single dose vials are much easier to track than multi-dose vials. So when you're doing that little cost benefit analysis, even if the multi-dose vial is maybe a few pennies cheaper, like there's also an opportunity cost with all of the time and investment that your team is going to spend trying to track down and make sense of like what happened to the remainder of that third of a vial. So considering the ease of tracking when you're making those formulary decisions, I think is important. And then I don't want to throw any like shade on any folks in the equation, but I would just like to kind of lift up as a positive example that I've seen is nurses and medical assistants seem to have like really consistent documentation of the work that they're doing, and they seem to often be documenting in like discrete data fields in the EMR, which are always going to be easier for your IT and BI teams to pull into a report for you. A medical provider who has a whole 20-minute visit and they're doing their HPI assessment and plan, if they free text, so I also gave a dose of Depo in the free text, that's going to be really challenging to just pull into an automated report. So maybe prioritizing drugs that are used in clinic that are documented in some of those discrete data fields. Those would be better candidates for 340B purchasing in my mind. And since we found from our poll question that a lot of people are using paper logs, we got to talk a little bit about paper logs. There can be a role for paper logs in clinic-administered drug tracking, but it might involve some systems of support around the paper logs. It might even involve transcription of the paper logs. For for auditing purposes, whether it's maybe your external audit that you engage in, or if you have HRSA come for a formal 340B audit, they'll ask for your patient administration records, and they say that they prefer to receive those in Excel or some other electronic documentation. So certainly if you're getting data out of your EMR, that's going to be great and pretty ready to use in electronic format. But if you are relying on paper logs for all of your clinic administered drugs, does that mean that you're transcribing those logs periodically, or only waiting until you receive an audit and the auditor confirms that no, we really want you to convert these to an electronic audit? So it's just something to think about if your only source of tracking is a paper log. And then just because, I used to be like working a process improvement field, I can't really let that fully go. If you're thinking about your paper logs, I would encourage you to think about the location of where that logbook is. So sometimes in a clinic, you'll see that we have like reproductive health or women's health drugs over here, and then we have another med room over here, and then we have our big logbook that's over at the MA station. Well, if the folks who are using that log have to walk between the place that they got the medication to where they're going to go do their documentation, in a busy clinic, they could get tapped on the shoulder by a provider or a patient or unknown number of things in that 20-foot walk to the logbook. And once that attention is changed to that next immediate task, it's going to be really hard for folks to remember to go back, oh, I forgot I didn't log out that in the paper log. So if you can keep your logs right where the drugs are, and even if that means having more than one logbook, I think that might help you with getting more consistency in your paper logs.
And to build on what Hannah talked about with the paper logs, that's what our clinics were doing. It was paper logs, and to audit those, you have to collect them. You have to try to read the writing, which in a HRSA audit is dreadful if you can't read the writing or the date of birth. And then, like she said, just the location of where they're documenting it. So one thing that I worked with our team at the time to do was to create an Excel document for the logs. And we did it on a secure share file, where now you have this log at every computer. It doesn't have to just be, you didn't have to purchase a computer to go in the drug room. Wherever they're documenting that administration at is where they can go ahead and put it on the drug log. So when we're looking at not recreating the wheel, we're looking at the medication tracker from the Apexis PVP program, where it gives us all the fields that we're looking for when tracking. So the date, the amount of inventory that was used, the patient name, date of birth, lot number, expiration date, the quantity administered, and then keeping the ending balance there, as well as who the staff that is providing the administration. And then the notes column. So when you see the notes column, this really gives you the ability to track everything in one place. So you can track your inventory, your waste, your audits, if you have someone that's coming to count, to make sure that whatever the ending balance is what's on the shelf. You can document that right there in the notes section. We have, say, a failed insertion, which would be waste. We're able to document it all on one spreadsheet.
And then Lanika, hot off the presses from our friends at Apexis, they have updated their tracking log to be in Excel now. So before it was in Word, and that is new and exciting. So I wanted to share that.
So to not have to recreate the wheel is always great. If we do we have a link yet, Felicity, for it?
No, but we will pull and share in the chat.
And I'm working on getting Rebecca our template, just the one in the background there, and we can upload that as well.
Yeah, certainly easier to work in Excel than in a Word document. Yeah, for something like this. Yeah.
We're gonna attempt to link the link to this one that's in the background that Chelsea and I kind of work together to create, because this is a problem we see across the board with clinic administered drugs. Is just, where are we tracking? do I have to keep up with the inventory log, a dispense log, and then an audit log? Having that all in one place is what we want to do.
Great. So kind of, I mean, I love, Lika, your like kind of robust centralized log. Something that I've seen be successful is another kind of hybrid between a paper log and a shared electronic log. And this was a process designed for tracking long-acting reversible contraceptives, so like your IUDs, your Nexplanon, because you're probably not doing a tremendous volume at your health center or your clinic, but they're high value items and they're important to track pretty carefully. So what we did was we assigned each IUD or LARC a unique identifier, and that got printed. We printed 2 sets of labels with the same number. So the numbers went on the box, and then they also went on the corresponding logbook page. We built the process around these kind of batches of 5. So the devices themselves were always delivered in batches of 5s, and that always corresponded to one logbook page. And the benefit of that was that if you look at your shelf and the whole batch of 5 is gone, you should have 5 patient names in that logbook page. And if you don't, then you have kind of this immediate visual clue that one of the devices did not get logged out in the paper log. So that was pretty helpful for, finding out in real time, like, oh, we forgot to write in the paper log, as opposed to at the end of the month trying to go back and parse out which patient maybe got missed. And in this process, it was a lot of effort. It was designed with the paper logs, and then there was one person at each clinic who was responsible for transcribing those paper logs into a centralized spreadsheet that was utilized across all of the clinic sites for the organization. So it was an effort, but it was really successful at tracking each device, like pretty wildly successful. So.
I want to add to something you said as well, Hannah. When you're looking at it, I encourage people to have your nurses spot check if they're putting an end imbalance in that end field, even if they're paper logs, what they're writing, they should be validating and making sure that's there. So then if they are doing that and you realize the numbers don't match up and you're able to investigate it, say the middle of the month versus I just looked at the log 2 months down the road, we can't find where it went. It kind of is good to spot check it during the month, so you can it's easier to narrow down what was missed. This is something that we kind of worked on creating as well with our electronic logs, is turning those specific sheets or drug logs into an inventory snapshot. So you can have the drug log formulated to populate into an inventory. So your drug name, your NDC that you have on the drug log auto populates in the inventory log. Whatever the current balance on hand that's showing on that drug log could auto populate in the inventory log. And then if you want to get fancy, you can put a minimal threshold. So if you want to keep 5 on hand at all times and 4 is used, it'll give you your what you can project to order to replace what was used. And it also keeps down on the overusage of or over ordering of inventory, having inventory that you're not using every month just sitting there. And once your staff gets used to it, you will see that they'll notice their patterns of how many drugs of each drug that they're using, and you'll see that the over ordering will go down a little bit.
Yeah.
Before we hop into kind of the quality of administration records and kind of that portion of diversion auditing, I was wondering if we could go through a couple of things that have come up in the chat in real time. So we've got, all right. We have Christina said, we have our formulary on a Google Sheet. The clinics are using paper logs for tracking administration, and we label all 340B inventory with a green 340B sticker we have created internally. It's difficult to move clinic staff to all electronic for various reasons, but it sounds like you have a really nice hybrid type version in place, which is very convenient, especially when you can't get everybody over at once. Let's see. Rana says paper logs in the clinics matching with ordering and a secondary check on those J-coded items for the billing in our EMR. If the drug does not have a J-code and is cheap, like ibuprofen or Benadryl liquid, then we order it on the retail account. That makes sense as well. And we have a question from Laura. For meds in an emergency box, how are you documenting usage if someone receives a medication that has not been a patient at the clinic? Which is a great question. And there are a couple ways to handle it. It looks like we have an answer in the chat, so I'll tackle that and then toss it over for you guys for any additional input. So Megan shared that they have a policy for replacing that drug with a non-340B purchased drug if it was 340B purchased originally.
And so I'll jump in and add to it. So that's one of the ways that we can address this. And that would be the scenario that you would use if you are not able to maintain auditable records that would be able to be produced in the event of a HRSA audit. And so what's important to know is that if an individual is in any of your care settings and has a medical event, they may not have been your patient prior to that moment where they have a medical event, but they will become your patient in the context of you managing them in that emergency. And so the question isn't, are they 340B eligible or not? Because if you are treating them for a medical event, they are your patient. Ryan White, your grant may put you in a different situation. So we do have an STD grantee here in the room. You are our exception. But everybody else in the room, it would fall into the context of your grant or your hospital. And so from there, you need to think about your auditable records. And so HRSA does have opportunities that it could be. So Megan's asking about your four walls. I'm assuming if you're stocking a 340B item in the location that it would be eligible. So let's assume that the location is eligible as well, because otherwise why do you have a 340B product there? So we're just going to have some assumptions. And so, okay, you're getting really deep into a scenario, Megan. So we're just going to take a general scenario. A patient is in your hospital, but they're not your patient. They're with a family member. They've had an incident in your ER, and you have to manage them because their wife's having a baby and they've passed out. Okay, that's the scenario, or something to that effect. But if you have documentation to support the administration, it could even be a paper record. If you were able to reproduce that in a HRSA audit, they would be considered your patient for the context of that treatment, because as long as they're at an eligible location, receiving care from a healthcare professional employed or contracted with your organization, that you're maintaining responsibility of care in that episode of care within scope of grant, you would be able to use your 340B medication. The question is, are you able to have that documentation? A lot of times what happens in those code scenarios is it's written down on paper, and that paper goes into the cosmos. It does not make it into a place that is retrievable. And so the scenario of replacing it with a non-340B item is a great way to handle it. But if you are able to track it, you could use 340B for those scenarios. And Megan, you
And
are in the weeds.
Both the hospital that I worked at, and I believe the health center, the health center I worked at as well.
Yeah.
We had a process in place for almost like an abbreviated medical record for those instances, because those emergency situations often aren't documented, as Felicity said, in the medical record in real time, right? It's in that emergency sheet that's in the emergency box for documenting what occurred and what medications were administered. And then there's a process oftentimes in place for that to get entered into the medical record, maybe in an abbreviated medical record entry. So you might not have all of the patient's information in there that you would if they were a patient that had established with you for primary care or was admitted for a hospital visit, but you still have their basic information and the administration and medical care documentation as well.
Very
Um,
thorough example, an explanation on the emergency boxes.
Mhm.
Yeah, it's a
We
good
also have one other thing that's not Megan's very in the weeds example, which is glorious. I'm glad that you're helping people out on the sidewalk with Narcan, but that does present some other issues that perhaps your compliance and legal would want to weigh in on. We have to contact, Amber shared, we have to contact nursing for manually entered NDCs with no purchase history and our coding department for wrong J code or NDCs for documentation challenges. And that's unfortunately fairly common,
Very common.
especially like some EMRs. And when I say that, I will say, Felicity and I can speak from personal experience. You put in a J code in the EMR and don't assign an NDC. And even though everybody and their mother for years has told you that no NDC is billed, something happens, some magic, a gremlin living in the middle of the medical record, and just drops a random NDC on the bill as it goes to the payer. So definitely a common challenge to have, particularly if those NDCs are getting kind of pulled arbitrarily and don't align with products that you have purchase history for. All right, now I get back to you.
Okay, great. So I think rightly so, people spend a lot of effort and discussion, as we have today too, about like tracking the units, and that is very important. But there's also space for auditing your clinic administered drug records themselves. So what that means is, with your data that you have, whether that's coming from the EMR or coming from your logbooks, going through and looking potentially at a sample of those and assessing, was this clinic administered dispense? Was it associated with an eligible patient? Was it an eligible location and provider? And then again, that third prong that we don't want to forget is, does it present a duplicate discount risk? So some people will do a sample audit, maybe half of it random, then some targeted by the drug, some targeted by the clinic location, however you want to set that up. But it is enlightening to go actually open the patient chart and look at some examples of the documentation and just make sure that what you expect matches with what your documentation reflects. Like the first question is, can you even, if it's a paper log, for example, can you even find that patient in the medical record based off of like how it was written in the handwriting? And then this is a tool from Apexis. This is a self-audit tool that you could use for performing that exercise of going through and looking at individual clinic-administered drug dispenses. So just want to give credit to all the amazing tools that are already out there for folks to use. Yeah.
So also, when we're considering our self-audits for clinic-administered drugs, we want to also audit tying out those purchases. And a good way that you can do that is another Apexis tool, which is their PVP historical purchase report. Running that report by date. So if you want to run it for a month, this report will show all of your purchases across your clinics, your pharmacy, your in-house pharmacies, and your contract pharmacies. And looking to make sure, are also running that report, run the report from your wholesaler, and tying out the purchases to your drug logs, as well as just looking at that report, the historical purchase report, and making sure that there's no account numbers that is not already on the crosswalk that you created for all of your different clinic accounts. We see a lot of times where there are accounts open that maybe the 340B, the person that is overseeing your 340B program didn't even realize that someone else opened a 340B account. So this is a good time to look at that, if your crosswalk, and tie it back to this historical purchase report.
Yeah, that's a good point. Let's see. So kind of building off of that, when you think about implementing an audit around the volume of purchases that you have, probably the for clinic administered drugs, probably more likely that the actual dispense records you're getting out of your electronic medical record, they're probably more likely to be an eligible patient because they were here at your clinic, and probably a compliant use of 340B. But beyond just that, you want to be auditing to make sure that the number of administration records you have is appropriate for the number of units of that medication that you're purchasing. So one way you can do this is you can ask for each clinic to provide you with an inventory count on a set cadence. So for example, like at the end of the month, every clinic could send you a list of, here's our 340B formulary, here's how many units of each medication we have. So in an example, say at the end of April, if the clinic said we have 10 doses of depot left on hand, and then in May, you know that you ship them 50 new doses from the wholesaler, and then you pull your records out of your medical record or your log books and you see, okay, well, I see that you administered depot to 40 patients. So if you do the math there, you would expect that at the end of May, when they give you your count, you'd expect it to be 20. That's how many you would expect them to have. So the audit, in a sense, is comparing what they tell you at the end of May to what would make sense for them to have based off of their administrations and the new products that they potentially received.
And at the bottom of the screen, you'll kind of see a snippet of an example of what you could use to reconcile your 340B purchases down to an audit. So looking at, like Hannah said, your starting point, the quantity received, if anything expired or waste, wherever it went, the utilization, and then getting that end count. And if you have a variance, what are we doing to reconcile these? Are we going back and looking in the chart, see if something was missing? Was it waste? HRSA's expectation is that we provide oversight over it. They don't expect for it to be perfect, but if we have 50 that we ordered and 48 of them went away and we have no clue where they went and we can't show any oversight, that's where we have a problem. But if one was missed or dropped and it went away and we notice it went away, we document that information, that we have the oversight, we realize they went away, documenting that variance, keeping those auditable records, then we're okay.
Yeah. That's a great
And the
point.
template for that that's at the bottom of the screen there is the last tab on the FQHC 340B template that we uploaded, if anybody needs that.
I would say one more thing, if you're implementing this, a piece of grace to have with the process is that you're going to be asking someone, probably a human, to count the inventory at the end of the month. And they're not always going to count on the last calendar day of the month, because that might not be a day that they work, so there could be a little variation of the time of the day or the time of day that count happens. And then also when you're looking at your new purchases that came in that month, you might be pulling a report, like say pulling the May purchases, for example, but if it was purchased towards the end of May, and maybe it didn't actually get delivered until after that person did their count. So you have to think through these other scenarios and not jump to conclusions that like, oh, all these depot are lost. Just kind of like, now I put my investigator hat on and try and figure out what's going on here. But yeah, so now the fun part, that third prong that we've mentioned, started teasing several times, your duplicate discount considerations for clinic administered drugs. So this is me, I guess, like living out my investigator persona that is hiding deep down somewhere I didn't know about. But you want to make sure that you understand your specific state's requirements related to clinic administered drug billing in the 340B space. And there is quite a bit of variation between different states about what they're going to expect. So maybe you've made some great friends in the 340B world and you have an awesome friend from a few states away and they have a great CAD process and you just go to implement it. But it just would give you a sense to pause and make sure that you understand what your state Medicaid agency is expecting to see. So they might be expecting to see that you either carved in or carved out. Some states want to be mandatory carve in for 340B. Are you billing multiple different states? And have you considered the billing requirements for each of the state where you're seeing patients? And then does your state require a claim level modifier? So like in addition to being on the Medicaid exclusion file. So I think our poll question, we have people starting to answer that. And the question is, what does your state require for clinic administered drugs? So claim modifiers or Medicaid exclusion file. And it's a little bit of a trick question because sometimes they might require both, or maybe you're not quite sure what your state requires. So yeah.
The claim modifiers are out front by a long shot for most of everyone in the room.
Yeah. Yeah. And, maybe they utilize a claim modifier, but maybe that's not super well published. So there is some work to figure out what your specific state is needing. And then I just wanted to give a plug. This other screenshot on here is the Apexis tool. They have a tool that can be a helpful starting point if you're looking to kind of get a base level understanding of what your specific state might require. And then we'd always recommend that you use that as a starting point and then validate that information with the state specific sources. So they'll typically give you links or a name of a contact person. So you'd want to go and make sure that that's still accurate for your state. Let's see. So for duplicate discounts, if your state, so 11 of you said that your state is utilizing that Medicaid exclusion file, so the MEF. So if your state's utilizing MEF, that means that you need to be consistently billing for your clinic administered drugs under the Medicaid billing number and NPI that you have listed in the Medicaid exclusion file. So this is the Medicaid billing number and the NPI that you have rostered in OPACE, and you've essentially told the government and your state Medicaid office that, hey, we're using 340B in this setting. So everybody knows. So you have to make sure that that's where you're consistently billing for those clinic administered drugs is under those numbers that you've rostered. And as a side note, it can make it a little more challenging to decide on your formulary to, buy some things on 340B and some things not, because all of the bills under that Medicaid billing number and NPI will then be absorbed and seen by external stakeholders as utilizing a 340B drug. So that's just a consideration there. And then Lanika, if you wanted to add about modifiers.
Yeah, so I want to add about modifiers, but I want to clarify one thing as well, because we use the term billed as in a lot of people look at it as charging the patient or not charging the patient. So a lot of times I get the answer, I'll get we don't charge for our injections, or we don't charge for the drugs that we administer in this encounter. It doesn't matter if you are bundle billing that drug. If that J code shows on your fee-for-service billing form, then if your state requires a modifier, that modifier needs to be there. It can say zero by it, you didn't bill them. But that modifier is telling them that this is 340B, and though I didn't charge for it, a Medicaid rebate could still be sought for that drug. And then I think that kind of hits what I was going to say about states excluding claims from the rebate based on claim level modifiers.
Yeah, and I think that fits in with our next slide, which is actually going and pulling some samples of your clinic administered drugs and asking your billing team or your billing folks, hey, can I receive the billing form? So either the HCFA 1500 form, maybe you're using a UB04 form, give them a list of however many samples you've decided, ask for those specific patients' billing forms. And then what you're going to do is really review the Medicaid billing numbers and the NPIs that are used on those actual human live claims that got sent to your Medicaid programs, and make sure that those Medicaid billing numbers and NPIs are, for example, included in your Medicaid exclusion file, which you can download from the HRSA OPACE website, and anyone can download it. You don't have to be logged in to be able to perform that function. So it's an important step in the auditing, and one that I think can be overlooked because there's so much complexity in just tracking the units of clinic-administered drugs that sometimes people forget that, oh, there's also a Medicaid piece of the equation here on clinic-administered drugs.
And I know we're getting close on time. I wanted to add to that really quick. If you have if your EMR software can track down to the modifier, essentially, say like Epic, you can run a report for your J codes and add the NPI modifier to that report and essentially check all of your clinic administered drugs every month for duplicate discounts. But it's according to your EMR if they have that capability, but that's one way to think about it. But with the forms, at least twice a year, if not every quarter, because you don't see what billing is doing every day to make sure that the solution is sticking. You may tell them we need the modifiers, use this NPI, don't use that NPI, and they may do it for a while and then someone else may do it. It's not one of those set and forget type situations.
Yeah.
Right.
I'm gonna say that we're gonna skip for hot topics for this time.
Content that is in the slide deck that is uploaded.
Yes. It looks like some people are having issues. So I see Rana, you're saying it might help her to turn off the camera. It's not frozen for, well, it hasn't been frozen for everybody. I think it's the host website. I got a message from someone else on our team that it disconnected all the way for her and then brought her back in. She had to leave and then come back in herself. But all videos have been coming through on my end. So it's not it's not Hannah's video specifically.
Yeah. And Hannah's video will be there in the recording because we did not lose her during the session. So if there was anything that Hannah said that you did not hear, it'll be in the recording that will show up in your inbox usually within an hour. So there's lots of great content in the hot topics. Some of the slides are not our usual color. We were in crunch time, but looking forward to
Nobody would have noticed. You don't have to call that out, lady.
It's not operating.
We have one
chai. We are looking forward to seeing you there.
We had one question come up in the chat that I do think, since we have a couple minutes, is worth just bringing up because I think it's a question that comes up pretty frequently. So Kelly had asked, do we need to have all Medicaid billing numbers listed on every site, child or associated, if we're only billing under one NPI, so your primary site's NPI? So Felicity answered, you only list the billing numbers you bill under on the Medicaid exclusion file. But you do need to do that under each site that you are using it to bill. So if you're using the NPI from your primary site, your zero site, parent site, whatever it's called based on your type of covered entity, that NPI does need to be listed on the Medicaid exclusion file for each 340B ID that uses it.
And that's pharmacy, the pharmacy NPI as well, if you have an in-house pharmacy and that's sometimes forgotten about.
So we look forward to seeing you all next month. We're going to have a little bit of a different topic. So we're going to be talking about imposter syndrome, which is not 340B related. We will have hot topics next month, which we are going to desperately need to get to because there's been a lot this month and this was so important. And again, you can peek at what's there, but we'll be getting you up to speed on everything that's been going on. But we'll do some discussion on imposter syndrome, which is something I think that a lot of us have either dealt with, will deal with at some point in our careers. So just really appreciate Hannah, you joining us. It was fabulous to have you here. Lanika for also taking the large portion of that presentation. You two were both amazing experts for this topic. And thank you everybody for being here. Chelsea, as always, for being our wizard for everything, moderating and making slides beautiful. Everybody have a wonderful week. And if you are at the NACS CHI, please stop by and visit Chelsea and Lanika from the time it starts, and I will be there for 340B Day. So we look forward to seeing everybody. Have a great day.
Thank you.